Good morning. How is everybody? Good. Last week. Actually, today is the last skills day. So we have 3 skills to learn today. You will have some practice time, after class today or, at the end of class today as well. But today is the last skills day. Wednesday, we're going to be going over employability. I'm going to help you answer the tell me a little bit about yourself question that's going to come up during interviews. I have a formula that you can use to craft a statement that makes you instantly attractive to employers. So I'm going to help you with that. That's tailored specifically for you. We're going to go over how to find a job in healthcare because it is a little bit different than finding a job in other industries. All your normal go-tos don't always work when you're trying to find a job in healthcare. We're going to learn about how to renew our certification, as well as how to do our continuing education that we're going to need to renew. So we have a lot of things to cover on Wednesday. We're also going to take a class photo that I'll post on Facebook. I don't tag you guys. You can find it and share it if you want to. But we will take a class photo. So please make sure that you are wearing your class t-shirts on Wednesday. You'll also want to bring back your yellow book. I will be collecting that in class on Wednesday as well. The white book is yours to keep forever. All right, any questions before we go on? Let me go ahead and get your scores for chapters 8 and 9. Kayla?
8 was 75% and 9 was 95%.
Thank you. Do you have 5, 6, and 7 for me?
Yes. 5 was 85%. 6 was 80%. And 7 was 100%.
Thank you. Felicity?
95 for both.
Do you have 7 for me?
That's a 9.
Thank you. Jamie?
100 for both.
Thank you. Peyton?
85 and 90.
Thank you. Gloria?
95 and 100.
Thank you. Kenley?
100 and 100.
Thank you. Melissa? Nancy?
I don't have it. I missed Wednesday.
Okay.
I don't even know what y'all did.
Okay.
I have to get with you after class.
Yeah, your syllabus will cover it. This paper
Yeah.
will cover, yep, it covers what we do each class.
Mm-hmm.
So you'll be able to see what you've
So that
missed.
would be class 6.
Right,
Okay.
because this is class 7. So for chapter tests, I'm missing 7, 8, and 9 from you.
Okay.
And then, of course, you'll have 10 to do tonight as well.
Okay.
Jasmine?
Yeah, I'm missing a couple.
Yeah, I need 5 through 9.
Okay, so 5 is 100, 95, 100, 195.
Thank you. Yeah, we haven't got to 10 yet. Jose?
95 for both.
Jose, do you have 5, 6, and 7?
5 is 90. 6 is 95. 7 is 95.
Thank you very much. Alani?
85.
Thank you. Amelia? Isabella? Do you have 5 for me? Or I'm sorry, that's 7 for me. Thank you. All right. Any questions on any of the chapters? Anything that you've missed that you're not real sure why your answer was not correct? Anything you need me to explain to you?
Is the midline of your body your hips?
Midline of the body is if you took an imaginary marker and you went straight down the middle, all the way down. That is the midline of your body. Okay, it's the right. It's like this. So there is another one, which is a sagittal plane that cuts you. Cut's not the right word, but divides you here. But we don't use that at all. At all. Yeah.
On the chapter 9 test, the question I missed was like, which of the following statements is true regarding a prosthesis?
Right.
And I circled like phantom pain does not need to be reported. And the right answer was that patients can decide not to wear it daily. So do we not need to report phantom pain? Like that's not necessary?
No, phantom pain does need to be reported. So read the question to me again.
Which of the following statements is true regarding a prosthesis?
Okay, so which of the following statements is true? So let's look at that last statement, right? Phantom pain does not need to be reported. Is that true?
Oh, okay. Makes sense.
So we do have to report all pain. Yeah. So, and you may have a question on the state exam that's worded like that. So when you have anything, any exam, no matter what industry you're taking, right? If it has the words, all of the following except, or which of the following is not, what you're looking for is not the right answer. You're looking for the wrong answer. Okay. But the way that you figure it out is you take each one of the answers and you plug it into the question. So, for instance, let me go to that one. This is chapter 9, right?
I have that.
Okay. So let's plug it in. Yeah, I know it can be a little confusing. Let's plug in each one of those. So is this a true statement? Every prosthesis must be soaked in a cleaning solution daily. No. So that's not the right answer. Stump socks should not be used to avoid slipping. No, we do use stump socks, and because we want the prosthesis to be able to grip well. Okay, so that's not the right answer. Phantom pain does not need to be reported. We've already talked about that when we report all pain, so that's not the right answer. So let's look at the last one. Patients may decide not to wear a prosthesis daily. Do patients have the right to make decisions regarding their own body? So that is the correct answer. Does that make sense? So if you look at each answer individually and kind of plug it into the question, it'll help you figure out which statement is correct and which one isn't. Remember, patients. So the best way to think about patients, guys, and we tend to, trying to figure out how to put this nicely. As healthcare workers, we tend to think about patients as children, right? We say you're going to do something, you're going to do it, right? We tend to put them in that kind of category. These are adults. If you can't make somebody do something in the checkout line of Walmart, you can't make somebody do something in a medical situation either. Okay. So a good way of thinking about this is if this patient were living in their own house, if they were living in their own house, would they be allowed to do this? So would somebody be allowed to decide not to wear a prosthetic if they were living in their own house?
Yes.
Well, then absolutely, they can decide not to wear a prosthetic in any other setting as well. Can a patient refuse a shower in their own house? I mean, there's days that you probably don't shower. You just make that decision. And there's no shower police standing there saying, you got to go get a shower, right? You are free to make those decisions as adults. So we have to be really careful when we're working with older individuals that we don't cross that line, that we don't make them do things that they, for whatever reason, don't particularly want to do right then. So what do we do with that information, though? Yeah, we give it to the nurse. And the nurse's job is to go in and try to convince the patient that this is for their best interest. And the nurse's job is education. That's really the main domain of the nurse, is to educate the patient. Hey, I know you're not wanting to wear your prosthetic. Is there a reason why? Does it not fit well? Does it cause pain? Is it uncomfortable? Is it just a pain in the butt to put on? You know, what is it that's making you not want to wear this? And this is what could happen if you don't wear it, right? So now they're making informed choices. That's not the role of a CNA. The role of a CNA is to help the patient with those tasks, and if they don't want to do them, to relay that back to the nurse. Good? Make sense? It's going to be very, very important on the state exam because you're going to have a few questions about this. Patients have the right to make decisions. And the people that fail the state exam generally fail because of those types of questions. They think that if I tell the patient to do something, the patient's going to do it. And they select answers that have like force the patient or make the patient or prevent the patient or discipline the patient, right? That's not our role. So if you know your role and you understand patient rights, those questions become a whole lot easier. Does that make sense? Good. We have a game show coming up on tomorrow morning at 11 a.m. on my YouTube channel. It's not broadcast anywhere else. It's only on my YouTube channel. I'm going to be, I started writing the questions last night, and I've been getting some feedback lately that my questions are too easy. And this is a little bit frustrating for me because the practice test that we do, the game show, should reflect the state exam, right? Well, the state exam questions are easy once you've learned all this, right? So I'm getting feedback that the questions are too easy, but I've got to reflect the state exam. So I've increased the trickiness of the wording for this next game show. Made it a little trickier. You're going to have to think just a little bit harder about what I'm actually asking. And I've centered the whole topic around observation and reporting, which we know is a big part of what a CNA does. So if you have a chance tomorrow, those questions are going to be just a little bit trickier. You're good. A little bit trickier, but still encompass the way that the state might ask these questions. Okay. So it might be a good one to tune into if you're looking at trying to prepare for the written exam. One class left. Have you registered for the test? If you have not registered, what are you waiting for? You are never going to be more prepared than you are right now. You're just not going to be. So when you get your test date, that's a really good motivator to practice. Because you're going to be like, oh my gosh, my test is in 10 days. I better practice. You will never be more prepared than you are right now. Don't put it off. Remember, the holidays are going to get in the way. They just will. We've already talked about that. Nope. All right. We're going to talk about this tomorrow, but it might help you to do this between, or not tomorrow, Wednesday. It might help you to do this quiz before class on Wednesday, because what I'm talking about will make a little bit more sense to you. Not everybody is going to thrive in the same setting. You've got to figure out what setting is right for you. Now, this can be really frustrating in healthcare because you get out of CNA school and you take your test and you become a CNA and you think, all right, I'm ready to go. And the first place that you go apply is at the hospital because Grey's Anatomy, I don't know, you're looking for Dr. McDreamy. So you go apply at the hospital, but that may not be the right workplace for you. A lot of this is going to depend on your personality. Healthcare is given in a lot of different places, but there's a lot of types of healthcare that you are going to be eligible to perform as a CNA. So for instance, if you are the type of person that is easily bored, like you master something and you're ready to move on, You are not a do the same thing every day type of person, right? If you are easily bored, need a challenge, then a high acuity, high complexity setting would be right for you. Things like hospitals or rehabs where things are changing quite often. Home health care, not the place for you. You're going to be bored out of your mind. Nursing homes, not the place for you. Very routine. So your personality is going to play into this. When you get out and you start working, if you get into the wrong setting, you're going to hate healthcare. It's not healthcare that you hate. It's the healthcare you're performing at this moment that you're not thrilled about. So different settings are going to require different things. Now, if you're the type of person that does not do well with change, you like everything, you like going in the morning and knowing exactly what you're going to do and no deviation from that, hospitals are not the place for you. Absolutely not. Because you've got admissions and you've got discharges all in the same day. The 7 patients you start out with at the beginning of your shift and the 10 patients you end with at the end of your shift are not the same. Lot of change. Right? Well, if you're not good with change, if you can't juggle all this, you're going to wash out really quickly. And what will end up happening is you'll probably leave healthcare thinking that healthcare isn't for you. It's not healthcare that's the problem. It's the place you chose to practice healthcare. That's the problem. So you have to look at your own personality, but there's more to it than that. Are you the type of person that is intimidated by a lot of beeping machines? Are you more comfortable with just dealing with a human body, not all the stuff that can be hooked to it? Well, in that case, a hospital may not be the right place for you. You also have to think about your opportunity for advancement. If you are looking to move on, if you're looking for higher education, assisted living is not going to offer anything to you. A walk-in clinic isn't going to help you a bit. You might want to look at a different setting. Does that make sense? So you have to look at the shift that you want to work, how closely you want to work with other people, whether you're good with a nice tight-knit group of coworkers or whether you're more of a give me my job and let me go type of person. You got to look at the opportunities for advancement. Pay scale is going to play into this. There's a lot of considerations that you probably haven't even thought of yet. And we're going to cover them on Wednesday when we go over employment. But if you take this quiz, it's on our flcnatraining.com website under today. I believe it's today's review. But if you go take this quiz, it's 19 questions. It'll take you maybe 5 minutes, but it will tell you the right setting for you based on your personality. And it goes over it expands on every single one of these topics that we're talking about. The type of work environment, the acuity of the patients, the opportunity for advancement, pay scale. It's going to cover all of that in your report so that you can make the right decision for you. Good? There's 9 possible work settings that are covered by this. And it's scary accurate. It is scary accurate. So I've had about 1,500 people go through this. A lot of them are existing nurses and CNAs and people that work in healthcare to fine tune it. It's scary accurate. So it'll help you kind of narrow that down in a way that you probably wouldn't do otherwise. Good? So that's available. It's free. Just go take it. It's available to you. All right. I'm going to steal a chair. Any questions?
Do you have to know the MyPlate image for the test?
You have to know the My Plate image exists. Okay. Yeah, you don't have to know the actual percentages. Yeah. How do I put this? The My Plate is a guide. You just have to know that generally speaking, we can't live off of Coke and Cheetos. It's just not really going to work nutritionally. So the FDA has, made some suggestions to us. That's going to be important, especially if you're working in home care where you're helping your patients plan meals. You might be shopping for them. You might be creating meals, simple meals for them to keep up with their nutritional needs. So in home care, that My Plate becomes very important. And that is something that you do have to know as a home health aide because of the setting that you're working in. If you're a CNA working in home care, it's something that you really should know. And that's why nutrition kind of talked about it, because CNAs can work in home care. It's, certainly a setting for you. But that's really where it's going to be most used by CNAs. All other settings are going to have a nutritionist that will, the doctor and the nutritionist work together to plan out, registered dietitian works together to plan out the right menu, the right food choices for the patient. Still have to have a vague understanding that we really are what we eat. So let me give you an example of this. You guys ever go to the movies? Okay. So when you went to the movies, you generally ended up with popcorn and a soda, right? And when you ate the popcorn, you had to get a big soda because when you ate the popcorn, it made you thirsty. So why is that? Why does popcorn make you thirsty? Well, it's not the popcorn, it's the salt. And what happens is that salt isn't readily excreted from the body. We basically hold on to it. So when you eat that popcorn that has a ton of salt on it, all of that salt is now in your blood vessels. So your blood is now way saltier than it should be. And salt does a lot of things in the body. And one of the things that it does is it, from a chemical standpoint, regulates your heart rhythm. Calcium and potassium together will regulate your heart rhythm. So your blood being way too salty is not a good thing inside the body. Your body's like, whoa, hold up, this isn't cool. But we can't just pee the salt out. Doesn't work like that. So if we can't get the salt out of the blood system, then what we have to do is dilute it in the blood system. And the way that we dilute it is to push fluid into the circulatory system. Make sense? Right? So that dilutes that salt out. More fluid, less salt in the fluid. Good? This is why when you eat popcorn, you have to have the large soda and you're drinking it to try to help offset that saltiness in your blood system. The problem is that soda you're drinking is high in sodium. So for a couple of hours after the movie, you are like a salt lick. I mean, you are like full up of salt. But that also will raise your blood pressure. Think about your blood vessels, right? Those hoses. Well, if we're pushing in a whole lot more fluid in that hose, there's more pressure in the hose. This is why when you're helping patients, especially in home care, good luck. When you're helping patients choose the right snacks, or in a home care setting, you're creating their meals for them. If they have any sort of cardiac condition, fluid retention problem, kidney issue, we reduce the sodium that they take in. It's not the sodium that we're really concerned about. It's the fact that where sodium goes, water will always follow. Make sense? So you kind of have to have a basic understanding that we are what we eat. that our nutrition is going to play a very big role in our overall health.
One more question. sorry.
Sure.
Is there a resource or like a CNA for Dummies book online that you know of? You know, like if you're actually doing the job and you have like you want to look at something for reference. Is there a place where you direct people to do that at? Would it be your white book or?
Yeah, the white book is going to cover pretty much everything you need, but your best source of information is the nurse that you're working with, because they're going to be able to take that very basic information and apply it to this particular patient that you have a question about. So even though, let's say we're working with a patient that has congestive heart failure, has swelling, because their heart's just weak. It's not pushing fluid around real well. So there's a lot of swelling, especially in the legs. And the patient's on a low sodium diet. Okay. And you've got a care plan that tells you to give the patients that one patient some pretzels and cheese for snack. And you are thinking, well, wait a minute, they got swelling and pretzels are high in sodium and so is cheese. So are you sure this is the right snack for this patient? You would go to the nurse and you'd say, hey, this is a high sodium snack. That nurse can tell you, yes, that is correct. Good catch. However, this patient's serum sodium right now is low because they also happen to have a kidney problem. And during dialysis, they pulled off too much sodium.
That's wonderful. I imagine the nurse being, it's not your job to think.
That's possibly, and that's a very valid point. I don't have time to explain that. Your job is to follow the care plan. What does the care plan say? I mean, that's a very valid response, kind of mean. I would caution the CNA to make you a partner, not an opponent, but it is still a valid response knowing our role, right? Remember that nurse always has information you don't have about that patient.
The reason I only asked was just not to bother the nurse in particular, you know, assuming.
Right, but then you're making decisions.
I wasn't intending to make decisions. It was more of a informative or reference situation.
Yeah.
You know, for whatever reason, I just think maybe I hear the nurse tell me this. Of course, I'm going to do whatever they say. You know what? I want to know more about it. I want to know what's
Yeah, and you can look things up for sure.
And that's what I meant. Like, you know.
Yeah, you can look.
Directly.
Uncle Google is your friend. You know, you can look things up, but remember that's going to be very general information and not tailored to that particular patient. Usually, if you've got how do I put this? Nurses are educators. It's what we are trained to do. We educate patients and families all day long. And if we have a CNA who is inquisitive, asking questions, wanting to put those pieces together, why are we restricting sodium in this patient, but not this patient, right? They're starting to see the bigger picture and the puzzle pieces. Then that nurse will usually answer your questions. Now, it may be short. Well, the sodium level on this one's too low, right? So, but you're getting the information that you need based on the patient that you're asking about, where when you go on to Uncle Google and ask, you know, why, Uncle Google is going to say, well, I don't know. It could be this. It could be this. It could be this. It could be this. It could be the nurse doesn't know what they're doing. I don't know. Right? Because there's so many opportunities out there for that change to occur, so many options. So Google certainly is your friend for general information, but if you want to really be able to connect the dots in a much more systemic way, the best thing to do is to go talk to the nurse, not as a challenge, but more as I don't understand. Can you know, I'm really interested in this. And that nurse will probably, most likely, encourage you to become a nurse, right? So that's actually what happened to me. Yeah. So when we're totally off track again. When I first started working in healthcare, I worked in purchasing. I was 18 years old. I had a multi-million-dollar budget and I bought stuff all day. I was a paid shopper. This is awesome. For an 18-year-old girl, man, that is the ideal job, right? So that I was working in purchasing. Well, the problem was that I have a lot of why questions. And I started asking my supervisor, why are there 16 types of syringes? Why do we have to have these scissors for this surgeon and these scissors for this surgeon when they look like they're exactly the same? Why? And I drove her nuts with the why questions. Well, our sister department, so purchasing, our sister department was central supply, where they sterilized instruments and made packs for the surgeons. And there was an opening in central supply, and they didn't have it filled. So they always tapped me for those jobs that they needed somebody for. And I was young and very eager to please. So I always took those jobs, right? So I would work 8 hours a day in purchasing and then 4 hours a day in central supply. Now, in order to work in central supply, I had to have some sort of medical certification. So I got my CNA. Okay. So I now was working in central supply. They taught me how to sterilize instruments. I was building packs for surgeons. I was stocking all this stuff I'm ordering. I'm now stocking. So it helped me kind of connect some of those dots. But man, I came up with a million other why questions, what if questions. And my supervisor in central supply, his name was James, and I'll never forget him. He was an older man. He was an LPN. He was a little gruff, really rough around the edges. Knew his stuff though. I mean, he ran a very tight department, and there were only 4 of us in the department. Okay, so I mean, it was tight. After about 6 or 8 months, he was so tired of me asking all of these why questions that he went to our department head and said, I'm taking her and we need the afternoon off. And he took me to, this is up in Citrus County, he took me to with Lacucci Vocational Technical. And because my family did not, nobody in my family had ever had any higher education. That it just didn't, we didn't know anything about FAFSA or school or, nobody was even encouraging me to go, I mean, so he put me in his car. He did not warn me. He's like, come with me. Put me in his car and drove me to the school, sat down with financial aid, and I got enrolled in an LPN program that day. He believed in me, right? And if it wasn't for him, I wouldn't be where I am today. Because if he had said, you probably should go to school, I would have found a million reasons why I couldn't, right? But he took me. He didn't go with me. He took me and walked me through every step of the way because he believed in me. So don't be afraid to ask your why questions. You never know who is on the other end of that sees that spark in you and will help you get to that next level. Okay? So don't be afraid to ask. But if you're going to Uncle Google, you're getting very general information and it's not really going to help you.
Yeah, it's a good starting point generally, but I was just wondering.
Right.
Already established.
Yep. Now, on the other side of this is continuing education. And that's really where you're going to get very focused information. So that's the next, I'll be doing continuing education next year. We're going to have continuing education courses, but one of them is going to be the role of nutrition on patient health, specifically written for CNAs. Okay. So if you've got a question about the role of sodium, right? Why that, go take the continuing education. It's an hour of focused content on that one subject that tells you why and some of the different reasons that you might end up there, but it's tailored specifically for CNAs, not for nurses, because it's a whole different. Nurses, we're going to get into pharmacology. We're going to get into electrolyte transfer, sodium pumps, all of those really big microbiology things, right? That doesn't apply to CNAs. That's not what you need to know. So I'm going to be tailoring all of these specifically for CNAs, and that'll be next year.
Do you think it's smart to go from a CNA to an LPN to an RN, or just go straight to an RN?
Oh, that is a great question. I actually did an entire lesson on this. It's on my YouTube channel somewhere. Just type in LPN. It should show up. But it's all about economics. It's all about economics. As a CNA, and I'm going to overly generalize this, guys. I'm really going to overly generalize. But as a CNA, you're probably going to be making, let's just say $20 an hour. Let's give you the benefit of the doubt. Let's say $20 an hour, right? That's decent, right? But it might pay for your rent and your car and not much else, right? So LPN training is 1 year. So you make $20 an hour for 1 year while you're going to LPN school. And now after that year, you're now making $28 an hour. Now, like I said, I don't know the actual pay scales for everybody right now. It depends. But let's just go with easy number, or let's say $25 an hour. Okay. So now you're making more money. Now it's going to take you 2 years to get from that LPN to RN. If you're going straight from CNA to RN, it's 3 years. So do we want to spend 3 years making $20 an hour? Or do we want to spend 1 year making $20 an hour, 2 years making $25 an hour, and then we're an RN? So it's about economics.
I just didn't know if it was like longer for school. I know
It's not actually, because the LPN program is the first year of nursing school. So when you go back, so you get but you don't have to have any prereqs. So when you get your LPN and you go to what's called bridging to RN, you got to take that second year of nursing school. You've already done the first year as your LPN. Now you're taking the second year as the RN, but you have to get your prereqs in. So that's why it takes 2 years. It's not 2 years of focused nursing. It's 1 year of prereqs and 1 year of focused nursing. But you're making LPN wages in the meantime. Okay. So that's what I recommend personally. Withlacoochee is where I went to get my LPN. They just announced, they're up in Citrus County. It's a small school, state run, so the tuition isn't bad at all. And they just announced like last month that they now have an LPN to RN bridge for like $8,000. Yeah. Yep. So if you get your LPN through there, and it's LPN's probably, I don't know, maybe $5,000 maybe. You'd have to look at the numbers. Go talk to their financial aid. But, and then now you're making more money. And so you can afford that $8,000. If you go down to one of these for-profit schools, the big ones that'll take anybody, yeah, you're going to be paying about $60,000 to $70,000 for that same education. So to me, 8,000 is a whole lot better. And they're a good school. They've been around forever. Forever. In fact, my LPN instructor, this is back in the late 80s. God, am I dating myself? She actually still tunes in to my live streams every so often. Yeah.
What's the school name? Gucci something?
Withlacoochee. Yeah. Withlacoochee. WTI.
Okay.
Yeah. Or WTC now, I think it is. Yeah.
It used to be an institute. Now it's actually they turned it into a
College. Yeah. Yeah. So, all right. Any other questions? Way off track. Sorry. All right. Let's get into helping somebody with a bedpan. Today is all about toileting. Everything that we're going to go over today has to do with toileting in some manner. So if you look down the side, all of our principles that are involved, they're all spelled out for us here. There is nothing new to learn. We know to read the care plan. We know to do our opening. Every skill starts with an opening. Every opening starts with a knock. We know to evaluate if we need gloves. Spoiler alert, you do, right? You're dealing with body fluids. You know that you need a barrier. You know that anytime the patient is uncovered or undressed, we need a privacy blanket. You know not to hold anything against your uniform. You know how to clean a basin. You know the patient needs to be in the middle of the bed at all times, and you know how to end every skill. There's nothing new to learn here. Now, I am going to tell you, this is one area that I disagree with the test on. Okay. And you're going to see this in the video. You also see it on the screen. I have trained you that anytime the patient is uncovered or undressed, we need a privacy blanket. And I stand by that. However, the test has a very specific checkpoint that is going to keep us from using a privacy blanket for this skill. We're going to leave the sheet on the patient. So instead of using a privacy blanket, we're just going to keep the sheet on the patient. I don't like that. I'm going to be very honest with you right up front. Because when we're dealing with toileting, chances are that sheet is going to get soiled in some way. I don't like it. I think it's much more hygienic to take the sheet away, use a privacy blanket instead, and then at the end of the skill, restore the clean sheet on the patient. But there's one specific checkpoint that states ensure patient is covered with a sheet throughout skill. Now, until they change that to ensure privacy is protected, we're not going to use a privacy blanket for this one. So this is one skill where what I taught you is not going to be applied to the skill. But I still want to teach you that privacy blankets are important, because when you're out there working, I don't want you getting sheets soiled and leaving them on the bed. But for the test, we're just going to leave the sheet in place. Good. Now, if you look down here, you're probably going to be scratching your head. Somebody with your level of experience should be able to do this in 10 minutes or less. We're just helping them with the bedpan. But right next door to that tells you who's going to be the patient for this. A student. That means one of you. What? You are not going to be undressed. You are not going to use the bedpan. Somebody's going to put it under you and take it out from under you, and that's it. So for the test, you're going to remain fully clothed. They're going to put a hospital gown on over your clothing. But the care plan is written in a very specific way to help prevent any intrusion on your personal space. So if you look at the top of page 148, it'll tell you the resident has requested a bedpan. The resident is not wearing undergarments. So that means that if you are performing this skill and I'm the patient in the bed, if you try to pull my pants off, the evaluators can say, stop. Your care plan says they're not wearing them. Remember I said that evaluators have to follow the care plan too, right? Well, that care plan is also there to protect the patients as well. So if somebody's trying to pull your pants off during the test, the evaluator has a legitimate reason to stop them. Stop. It's not on the care plan. Now, the next part of that sentence says the resident is able to wipe themselves, to clean themselves. So if somebody tries to get into your personal space to clean you up, the evaluator can say, stop. The care plan says they were able to do that on their own. So this care plan is very, very specific to the test. In most cases, your patient may need some help cleaning, because when we're talking about bedpans, this is a bedpan. That's not much space. And when a patient is sitting here, their undercarriage is going to kind of fall down into the bedpan. So there is not much space to get in there and clean what has to be cleaned. Okay. So chances are, if your patient's using a bedpan, they're probably going to need a little help on the cleaning department. Good. But for the test, do they?
No.
Why? How do we know? The care plan. Okay. And it says the resident is able to move as directed. Cool. We can ask them to lift. That's the best way. Ask them to lift. Put their feet flat on the bed and lift their hips like a bridge. Slide the bedpan under. Have them lift to slide the bedpan out. Man, that is the easiest bedpan scenario there is. Your patients aren't always going to be able to lift, though. In that case, scoot them toward you a little bit, roll them on their side, put the bedpan against their bottom, and have them roll back on top of the bedpan to use it. And when you go to take it out, though, you have to hold the bedpan down so that they roll off of it. If you don't hold that bedpan down and somebody is sitting on it, do you know what's going to happen? Yeah. So you put the bedpan, have them roll on top of it. When they're done, hold the bedpan and then have them roll off. Good?
I have a small question. Where does the butt exactly go on the bedpan?
Okay. If it looks like a toilet seat, it's where the butt goes. That's the best way to describe it. Imagine perching on here. Yeah, not comfortable at all. So this is the way my mom, because my mom used to teach classes for me. The way my mom would explain it is the wider end of the bedpan goes under the widest end of the patient.
That makes sense.
Yeah. Happy birthday, Mom. Her birthday's tomorrow. All right. So you've got a lot of supplies here. And I want to talk about the very first one, barrier. Again, this is something I don't necessarily agree with, but you're going to see it in the video because the video is matching the checkpoints exactly. Okay. But it's something I don't necessarily agree with. This table is where your patient is going to eat their meals. It's going to bear food. Now, there's going to be a tray that holds the food. But I personally don't like toileting items on an eating surface, even with a barrier. I just don't like it. So the way that I prefer to do this skill is leave the bedpan in the drawer until you're ready to use it. Then take it out and put it under the patient. That way you never put a bedpan on this surface. But the test being what it is, we are going to put a barrier on the table and we're going to put our supplies on the barrier like we do with every single skill. I would prefer that you not do that in a clinical setting. Does that make sense? But for the test, we're going to follow the checkpoints. I have a lot of issues with this skill. All right. You have to learn your supplies, by the way. So for this skill, we're actually going to ask our patient to put their feet flat on the bed, right, bent at the knees, and lift their hips up like a bridge. And then we're going to put the bedpan under the patient. But there's going to be movement involved here, and I'm going to explain that in just a minute. Anything that's in that bedpan is likely to slosh during this skill. So what could we put on the bed underneath the bedpan that's absorbent that would keep the sheets from getting soiled? A chucks. So for this skill, we're actually going to put a chucks under the patient first, then put the bedpan on top of the chucks. Does that make sense? Good? All right. The one thing that you have to understand about bedpans is that they are a last resort. As a nurse, I have to go through a lot of different options. Now, toileting is usually dictated by the doctor in an acute care setting. So like hospitals, same-day surgery centers, rehabs, doctors actually write toileting orders. like bathroom privileges, which means the patient gets up and goes whenever they need to, just like you. You all have bathroom privileges. When you have to go to the bathroom, I don't need to know about it. Go take care of your business. Okay. You all have bathroom privileges. And in a clinical setting, that's ideal. I don't want to be involved in your bathroom habits. Don't need to, unless there's a need, right? Now, if you need a little bit of help somewhere along the way, getting there, while you're there, after you're there, whatever the case may be, then we would have bathroom with assist. That means you still are taking care of your business, but you need a little help somewhere in the process. So bathroom with assist. Those are ideal. That's our goal for everybody. But not everybody is going to meet that goal. In some cases, the patient may not be able to make it all the way to the bathroom. It's just too far. They have energy deficits, or they have mobility issues, or they have breathing issues that, the exertion is just too much. Whatever the case may be, we have a portable toilet called a bedside commode that we can bring in and put it right next to the bed. Now, it kind of looks like a toilet. It has a toilet seat, but instead of a toilet bowl that gets to be flushed, it has just a regular bowl that whatever the patient expels goes into. CNAs empty that and clean it. But it's still a pretty toilet-like experience for the patient. Make sense? So bedside commodes only used with an order, right? We can't decide as CNAs, hey, I don't think you need to be going to the bathroom. Let me get a bedside commode for you. Not our call. This has to be ordered on the care plan. Good? Now, acute care settings, it's going to be ordered by the doctor. Long-term care settings will usually be ordered by the nurse with approval from the doctor. Different mechanism there. Either way, it's got to be on the care plan. Now, if none of those work for me, if I have a patient, they can't get up and go to the bathroom, even with assistance, they can't get out of bed to use that bedside commode, even with assistance, I'm now left with just 3 options. The first thing I have to figure out is, are they even continent? Now, we learned about that last week, incontinence, right? So if they're not continent, bathrooms aren't going to help because they can't hold it. The valve is broken. So that way, if they're incontinent, we just clean and change every 2 hours around the clock. Toileting doesn't enter into this, okay? So if they can't go to the bathroom, well, if they're continent, okay, incontinent has its own little rules. If they're continent, they can't go to the bathroom, we can't use bedside commode. Now, I've only got 2 options left. I can use a catheter, but only if there's a reason to use a catheter. Not being able to go to the bathroom, not a reason. Not a reason. So catheters are used very, very sparingly. We're going to find out why in about 45 minutes. But catheters are going to be used very sparingly. They have a very high rate of urinary tract infection. And catheter-acquired urinary tract infections are not your normal run-of-the-mill garden variety UTI. These will kill you within days. It'll flat out kill you. They're very, very serious. I'm going to explain why in just a few minutes. So unless I have a reason to use a catheter, I can't just whip one out and, use it. So now all that's left, if my patient is continent, can't get to the bathroom, can't use bedside commode, and the catheter is not indicated, all that's left is the bedpan. Did you guys notice that's last on the list? It's last for a reason. It's under catheter. So catheters are preferred over bedpans. Why is that? Well, it's because bedpans are not easy to use. They're uncomfortable. They're messy. But more importantly, there's a psychological restriction here. You have been taught from the time you were this tall, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. Remember that we learned that memories that are made early are good quality memories and they stick around for a really long time. Well, just because I put a plastic pan under your butt does not mean your brain is going to let you go while you're in bed. Does that make sense? So when we use bedpans with patients, a lot of times we'll put the bedpan in place and we'll come back in 10 minutes and they haven't been able to go. And then 20 minutes later, they hit the call light. I really got to pee. So you try again, put the bedpan in place and they don't go. And a little while later, they hit the call light. I've really got to pee now. So you try again and they can't go. Don't get frustrated with them. They're frustrated with their own bodies. But the fact is they're in bed. And psychologically, that can be a problem. So there's a few things you can do to help. First, privacy. Privacy. People need privacy for toileting. Imagine that.
Not when you have grandkids.
Yeah, or kids. So if you've got a patient in a room that has a roommate 3 feet away and the only thing that's between them is this curtain, that's not a whole lot of privacy. Especially if that patient has a bunch of family members in the room. So this is a good time to ask the family, can you please step out for a little bit, go get a cup of coffee? We're going to be doing a few things in here, perfectly acceptable. Try to provide privacy. If the roommate, the other patient, is ambulatory, get this one set up for a bedpan and then take that one for a walk. Privacy. We also have to be considerate of smells as well. Your patient, if they're using a bedpan, is very much aware of the smell that they might be producing. So sometimes some preemptive air freshener is a good idea to help remove that psychological restriction. We also can turn the water on in the room. The sound of water helps with the urinary letdown reflex, but it also helps mask sound as well. And then you have probably my favorite. If you have somebody that really is having a hard time going, we've got to get them to relax a little bit. So if you get a basin of warm water and just have them put their hands in the warm water and close their eyes, that helps with the urinary letdown reflex. Yeah, we learned that from 12-year-old Mean Girls. If you were the first person to fall asleep at a slumber party, you probably found your hand in a cup of hot water, and it was designed to make you pee your own pants. Yeah. So these are all tricks that we can use. None of them will be on the test, but they're things that I want you to tuck away for future use. Because if your patient has to have a bedpan, they're probably going to need some help. They will also need a lot of patience from you. Good? Question? Okay. All right, so we're going to put a chucks underneath the patient before we put the bedpan in place. You already know how to do this. Clean rolls toward me. So you roll the chucks towards you, have them lift, and just unroll it under them. And then we'll put the bedpan underneath the patient. The widest part of the bedpan goes under the butt. Once they're in position, you might have to have them adjust the bedpan a little bit so it's centered. But the problem is that patients should not be using bedpans while they're laying down. Let me show you why. This is probably something you haven't really thought about on your own until I bring it to your attention. Okay, so if we have a patient Get this out of the way. This is our patient, right? Everybody see our patient? If I take the bedpan, are we good? If I take the bedpan and I put it underneath my patient's bottom, what does it do to their bottom? Raises it up. How many of you ladies can pee uphill? It's what we're asking them to do. The mechanics here don't work. If you think peeing uphill is bad, try pooping uphill. You need a certain amount of gravity to be successful here. So when you put a bedpan under a patient's bottom, it raises their bottom up. And here's a trick, guys. If you do this and don't put the head of the bed up, if your patient is able to pee, it's going to go right up their back and into their hair. That's horrible. That is horrible. Don't ever do that to a human. So when we put a bedpan underneath their bottom, we need to get them into a normal elimination position, which means we have to put the head of the bed up. Now they're in a natural elimination position. This, guys, the head of the bed is the most important step for this skill. The most important step. Because without putting the head of the bed up, you're setting them up for failure. But now they're sitting on that bedpan, pressing it down into the mattress. You're not going to be able to pull it out. Their weight is on top of it. So in order to get the bedpan out, we have to put the head of the bed back down, and then we can remove the bedpan. Good? Do you guys understand why? Head of the bed adjustments are the most important step for this skill. But with all of that head of the bed movement, you're going to get some sloshing, whatever's in the bedpan. So that's why that chucks has to be there. So we're going to talk about that. Yeah, that's a good trick that we can use. So that chucks needs to be under them. But remember that we put the chucks in place and then the bedpan. Then we put the head of the bed up, which means this bed is bending. Bed is bending. That bed is bending where the patient bends, which is where you just put the bedpan. So when you put the bedpan under the patient and you lift the head of the bed, that bedpan's going to shift. It's either going to go up or it's going to go forward. So tell the patient, you can adjust the bedpan once I get the head of the bed up. You don't want the head of the bed all the way up because that bedpan isn't going to be flat. It has to, if you get the head of the bed all the way up. So you want them reclined enough that they can use the bedpan, but not so much that it tilts the bedpan. Good? Make sense? Okay. So let's think about the logistics here. We put a chucks under our patient. They're laying in bed. We roll the chucks toward us, put it under the patient. They lift their hips, we unroll it, and then we put the bedpan under the patient. Our patient is not wearing undergarments according to our care plan. We now have butt juice gloves. You just put those gloves under a bare butt. They're butt juice gloves. Whether you can see it or not, they're butt juice gloves. Do you want to touch that bed controller with butt juice gloves? So what do you think you should do before you put the head of the bed up? Take your gloves off. That's right. Then we'll put the head of the bed up. We're going to let them adjust it however they need to. We want to make sure that they have their toilet paper and a call light. We are not standing next to them while they go. People do not go with an audience. In a clinical setting, you've got other patients to see. You've got other places to go and other things to do. But for the test, this is your only patient. This is it. You have nowhere else to go. So for the test, you're going to stand on the other side of the curtain and you're going to wait until they say, I'm done. Don't do that in a clinical setting. Do not stand there. Give them some privacy. But for the test, we don't have a choice. We have nowhere else to go. So you'll stand on the other side of the curtain and you'll just wait for them to say they're done. When they come back in, we're going to put the head of the bed back down. Now we've got to take that chucks and bedpan out. So we have to put a new set of gloves on. This skill requires 2 sets of gloves. We had another skill that required 2 sets of gloves. Anybody remember what that was? Denture care, yeah. So there are 2 skills that are going to require 2 sets of gloves. Good? All right.
Wash your hands before you put them
So great question. If you leave the patient's room, we have to wash our hands before we leave the environment. So if you're going away to take care of somebody else, yes, you need to wash your hands. If you're staying in the patient's environment and you're still working with that patient, you do not have to wash your hands between gloves. You do not have to wash your hands. All right, so please make sure they have their call light and their toilet paper before you leave them. You're going to step on the other side of the curtain until they say they're done. And then when they're done, you're going to come back and put the head of the bed down. You're going to get your gloves on. And when we take the bedpan away, again, we're going to have them bend their knees, put their feet on the bed. They're going to lift, and we're going to pull the bedpan out. But you want to pull both the chucks and the bedpan out together because you cannot carry an open container of urine through a room. If you trip on your shoelace, you're going face first into that bedpan. It's also a privacy issue. Nobody needs to see what's in that bedpan. So we're going to take the chucks and the bedpan out together and wrap the chucks over the bedpan for transport to the bathroom. Good. We're going to dump it. Where does it go? Toilet, wherever it normally goes. Now, for the test, there's not going to be anything in it because they didn't actually use it. They stayed fully clothed. They kept all their own body fluids inside. Please keep your body fluids to yourself. So this is a pretend skill. You're going to dump the pretend urine in the bedside commode, but you're still going to clean it the way you clean everything else. You're going to rinse it, dump that in the bedside commode. We're going to pick it up with a paper towel, dry the inside, dry the outside, and then we'll put it away with a paper towel. Okay. Once we get everything cleaned up, we take our gloves off and our patient needs a hand wipe. Remember, they cleaned themselves. We know where their hands have been. They need to clean their hands. So we're going to give them a hand wipe. I know where their hands have been. I don't want to touch that hand wipe. So I'm going to get a paper towel to collect the hand wipe and throw it away. Good. Then, once you do that, we're not going to use a privacy blanket for this, so don't worry about that. Then you can do your closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Bed's in the low position. Environment's clean. Open the curtain and go wash my hands. Skill is done. It's not a hard skill. It really isn't. But it is kind of a longer one. Takes about 10 minutes to do. In a clinical setting, though, we have a tool that we can use. And this tool is amazing. This is called a bedpan cleaner. And you'll see this in acute care settings like hospitals, rehabs, sometimes ambulatory surgery centers, some nursing homes, but not as many as used to be. This right here looks like a little shower head. When you pivot that over the toilet bowl like this, it starts to spray into the bowl, and it is a bedpan cleaner. That's its job. It allows you to use the spray of water to clean whatever's in the bedpan out and dump it right into the toilet. But you have, you have water under pressure hitting a flat plastic surface. You're going to get splashback. That's right. Same thing with the patient when they're urinating and the bedpan's only this far from their undercarriage, right? They're going to get splashback. This is why most of the time you'll have to help your patients get cleaned up after the bedpan. Splashback is a thing. But when we're cleaning bedpans, the problem is that this is the patient's body fluids, and we don't want that splashback to get into any of our holes or on our uniform. So if you're going to use this, you need to dress for the job. We're going to put an isolation gown over disposable. Right. You'll want full PPE. So an isolation gown over your clothing to protect the clothing. And then you'd want a mask and shield to protect the holes on your face from any splashback that comes out. Okay. Good. A word about masks. Masks do not protect against smell. So if you try to put a mask on to help with smell, it doesn't. What we used to use, and it's funny because social media, man, they do target, like they target. We used to use like Vicks Vapor Rub, and we put it right under our nose, and it helped cut the smell. I can't use Vicks because it makes me look like Rudolph. I mean, it turns my skin instantly red. So what I used to use is Vaseline with a couple drops of essential oil. Just go get a small little tiny jar of Vaseline, put a couple drops, and now you can, customize the scent to anything you like. And same thing, a little bit under the nose helps cut odor. Now what they have, and these are amazing. I actually reached out to the company because I want to feature this. Now what they have are they're clear. You can't even see them. They're little plastic rings that go right up into the nose. They just kind of hook onto it's not piercing. It just literally slips in to hook onto your septum. And they're infused with these essential oils, and they last for like 30 days. And they're being marketed specifically to healthcare workers to help with odors. And they have like a ton of different scents. So if you're particularly odor sensitive, that might be a really good thing to look into. Okay. Pretty cool. All right. Remember, the bedpan is going to be positioned underneath the patient's bottom. All right. Any questions on that?
The odor thing lasts for 30 days, you say? Taste is related to odor.
Mm-hmm.
Wouldn't you ruin a lot of future meals?
Well, you wouldn't want to, you wouldn't want to leave it in for 30 days. You're going to wear it. Yeah. And it comes with this little carrying case. Now, it might be a really good thing for appetite suppression. I think that might, that's something that,
Find an odor you don't like and then
right. Yeah. So, but it comes in with this little carrying case thing. So, you wear it during work, you put it in the case, and that just kind of protects it. And then you reuse it for up to 30 days. Yeah. But yeah, I'd be interested in kind of that. It's like latex gloves. You don't wear gloves when you're feeding somebody unless care plan tells you to, because the odor of latex is an appetite suppressant. Yep, you will actually kill somebody's appetite. Yep. All right. So any questions on this? Let's watch the video. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. After I've washed my hands, I'm going to get my supplies. I'll start with a barrier, unfolding it with the absorbent side facing up, and this is going to give me a clean place to put my clean supplies. And we're going to start with the chucks, and then I'll move over here to the patient environment. I need a set of gloves, a second set of gloves, hand wipes, and I'll need the bedpan, which will be in the bottom drawer. I'm going to open the drawer, but I'm not going to touch the bedpan until I put my gloves on. We'll go ahead and put the gloves on. I'll take the barrier and prepare it by holding it up with the absorbent side facing me, and I'm going to roll it toward me. And we're going to set that aside. I'll get the bedpan and the toilet paper out of the drawer, and we'll put those on the bedside table. Now we're ready to start the skill. Okay, Mr. Jones, I'm going to ask you in just a moment to bend your knees and put your feet flat on the bed, and you're going to lift your hips up for me so I can unroll this chucks underneath you. This is going to protect your bedding while you use the bedpan. Okay? So I'm just going to loosen this sheet up a little bit so we've got some working room. I'll take my prepared chucks, and we're going to place it on the bed. We're going to unroll it under the patient. It needs to be under the middle of the patient where the bedpan is going to go to protect the sheets from becoming soiled. Mr. Jones, can you bend your knees? And I want you to lift your hips as high as you can go. Thank you. I'll unroll that chucks all the way to the other end. Okay, you can relax. There you go. Now we're going to put the bedpan under the patient. The wider end of the bedpan goes under the patient's buttocks. So this will be toward the foot of the bed. Mr. Jones, can you lift for me? Thank you. Go ahead and come down. Make sure that that's centered appropriately. All right. And now I can remove this set of gloves. We'll throw these gloves away, and I'm going to put the head of the bed up. Mr. Jones, I'll put the head of the bed up now. That bedpan may shift a little bit. Feel free to move it as you need to, and let me know when you're comfortable. And you can relax your legs. Are you comfortable? Okay. Here's your toilet paper. Here's your call light. I'm just going to step on the other side of the curtain and let me know when you're done. Okay, Mr. Jones, are you done?
I am.
Very good. Let me lower the head of the bed. There we go. And I'm going to put my gloves on. All right, Mr. Jones, in just a moment, I'm going to ask you to bend your knees and lift your hips off of the bedpan. But wait until I tell you because I need to hold that bedpan flat.
Okay.
Okay? I'm just going to move this out of the way. I'll take a corner of the chucks. Go ahead and bend your knees. Don't lift yet. I'm going to take a corner of the chucks and hold the front of that bedpan down as he lifts. Go ahead and lift. And I'll pull the whole chucks and bedpan out. Relax. And we're going to take this to the bathroom for disposal. I'll bring the bedpan
over to the patient bathroom area. We'll unwrap the chucks from around the bedpan and dispose of the chucks. And then we're going to dispose of the contents of the bedpan into the bedside commode. For testing, this is a simulation skill. There will not be anything in the bedpan, but we're still going to follow through with the simulation. We'll lift up both the seat and the lid. We're going to dispose of the contents of the bedpan into the bedside commode or toilet. And then we're going to rinse the bedpan. We want to put the rinse water into the commode as well. Now I'm going to set the bedpan down into the sink, disinfect it per facility policy, and then use a paper towel to pick it up. I'll take a paper towel to dry the inside. Throw that away. Another paper towel to dry the outside. Throw that away. And then one more for the drawer. Now that I've cleaned the bedpan, I'll get the toilet paper, place it in the bedpan, open the drawer with a paper towel, and then we're going to position this bedpan in the drawer and close the drawer with the paper towels. I'll then throw these paper towels away. We're going to remove the gloves and throw those away. I'll get a paper towel. Mr. Jones, I'm going to give you a hand wipe so you can wash your hands after using the bedpan. Go ahead and take a hand wipe. And then I'll collect that hand wipe after you're done with the paper towel.
Thank you.
This keeps me from touching the hand wipe. We'll throw this away. We're going to throw the barrier away. Clean our work environment. So I'll pull the sheet up, make sure that it looks good. And here's your call light, Mr. Jones. If you need anything at all, just press that red button and we'll be happy to come back and help you. I'm going to remove your bedside table and open your privacy curtain. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your bed is in the low position. Your environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Right, we're going to go ahead and take our break. And the next two skills we're going to do is catheter care and drainage bag. And I do those two together. They're two separate skills on the state exam, but I show them together because they do go together. When you do catheter care, you will be emptying the drainage bag. But you're going to, for the exam, they will be two separate skills. You'll do your opening, skill, closing, opening, skill, closing. Okay, good? Go ahead and take your break. Come back in 15 minutes. right. There we go. All right, any questions on what we've covered so far? We're going to move on to catheter care now. Catheter care is pericare with an extra step. So you already know how to do this. There's a lot of similarities between pericare and catheter care, but in order to understand what catheter care is, we kind of have to cover a little bit about what catheters are and how they're used to take away some of that fear that you guys have about catheters. But we also need to talk about the risks involved with them as well, because this skill is all about infection control. So if you look on page 158, you can see all the principles involved. They're pretty much everything except for shoe rules. This skill is going to be done on a mannequin. That mannequin will be positioned in bed for the skill. And you're going to talk to the mannequin as if it were a real person. So if you look at the top of page 159, we can see our care plan. It says provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So catheter tubing and perineal area, which is the front. Remember pericare, we cleaned the peri area and the backside. Well, for this skill, we're going to do the peri area and the tubing. Got it? Reason we had to clean the backside for pericare is because the patient was incontinent, laying in urine. For this skill, the urine is going through a tube, so they're not laying in it, so we don't have to clean the backside. So if you remember pericare, we changed the chucks. We cleaned the, wash, rinse, and dried. We washed, rinse, and dried the back, and then we changed the chucks again. That was pericare. Catheter care, very, very similar. We're going to put chucks in place. They're not going to have it there to begin with. We'll put a chucks in place. We're going to clean the peri area, but we're not going to clean their backside. We're going to clean the tube instead. And we won't leave them on a chucks at the end like we did with pericare. The whole reason for that chucks is to collect urine. This patient isn't leaking urine. You don't want a chucks under somebody you don't need one under, because that chucks is plastic line. It's going to hold in body heat, warm, dark, moist, not an ideal situation. So only use a chucks if you need it. But let's talk a little bit about catheters. When we're doing catheter care, it's going to be done once a shift. Remember, pericare was every 2 hours around the clock. Catheter care is once per shift or as directed by your care plan. Okay. When you're doing catheter care, you also want to inspect the tube and the bag to make sure it's not on the floor, it's not above the hips, the tubing isn't kinked, everything's flowing right. Just make sure everything looks good. So these are the parts of this whole catheter system. You have the catheter where it's inserted into the patient. It's going to be held in place by a little balloon. We'll get to that in a minute. Then you've got the catheter tubing itself. That catheter tubing is going to terminate in 2 ports. One of those ports is used to inflate and deflate that balloon. The other port is going to attach to some sort of a collection device. So we're going to plug in this tubing from the catheter bag into this port. Now it's a closed system. Urine comes from the inside of the body down the tube into the catheter tubing attached to the bag and then is collected in the bag. Closed system. Good? Good? All right. So there's 2 separate pieces here on purpose. You have a catheter and then you have the bag. Catheters can stay in place up to 30 days. Nurses change out catheters inside the body up to 30 days. Bags, however, are generally going to be changed once a week. So if you have a bag changed once a week and a catheter that can stay in place up to 30 days, they have to be 2 separate pieces. CNAs, brand new, entry level, CNAs, do not separate those two pieces unless you have received additional training. You have to be trained to change the bag, and it has to be training for that particular patient.
So in CNA, is there anything we're restricted to even if we get training for it that we cannot still do?
That is going to depend on your state statutes, wherever your state that you're working in. In Florida, there is no restriction, but it's also going to depend on your policy and procedure for your facility because they're assuming liability. So your facility will define what skills CNAs can and cannot do in that facility. So first state statutes, then policy and procedure, then care plan with training. Okay.
Thank you.
Well, I have to say it that way because you might end up moving to a different state.
Yeah.
And even though Florida is wide open, the state that you move to may not be. So you need to know all three components to your scope of practice. You're welcome. That's a really good question for tomorrow. Jake, make a note. I'm going to make a question on that tomorrow. You guys will have a head start on that question. Scope of practice is defined by all of the following except. Okay. You guys can win a prize. All right. So the drainage bag is usually changed about once a week. The whole reason that you guys can't change drainage bags without additional training is because of the potential for infection. So, we just went over that. Okay. So this, guys remember this from class 2, right? The chain of infection. This is very, very relevant when it comes to catheters. And we have to remember, we have to have all of these things in place, right? You have to have a pathogen. It's got to have a nice warm place to live. It's got to have a doorway out. It's got to have a way to travel, a doorway in, and then that person has to be susceptible, right? Well, we generally don't go around putting catheters in nice, healthy humans. So your patients are automatically going to be susceptible. That is automatically there when we have a catheter because they're busy fighting off whatever's wrong with them. The whole reason they need the catheter to begin with, right? So it's an illness, it's an injury, it's a surgery, something like that. Your patient is already susceptible. So we have to consider that when we're talking about catheters as our patients are already at risk. And your body has built-in mechanisms to help prevent infections from occurring in the urinary tract system. So you guys remember this from last class. We've got 2 kidneys. Those kidneys filter blood. They create urine. That urine drips down these ureters into the bladder. And then there's a little valve at the bottom of the bladder that holds that urine in until you go to the bathroom. Valve opens, bladder empties, valve closes. You're good to go for a while again. You guys remember that? Well, hanging out here in our urethra and sometimes even in our bladder are bodyguards, bouncers. They're white blood cells. They're the body's natural defenders. And they're on the lookout for any bacteria that might be invading. And when they see a bacteria, they go, hey, you don't belong, get out. So because remember, this is a doorway in. It's a doorway into the body. And this doorway has direct access to your blood supply. Right here. This is dangerous. So your body recognizes that. Hey, any part of the body that has direct access to the blood supply has to be protected. You wouldn't have Fort Knox, just anybody can walk in and out, right? Right? We got to protect the things that are important. So that's what this is doing. So we've got these bouncers or bodyguards, these white blood cells that are hanging out, and they're catching the bacteria that are trying to get in, as long as the bacteria just shows up 1 or 2 at a time. But if we end up with a whole bunch of bacteria at one time, it overwhelms that defense system, and now we have a potential for infection. Does that make sense? You guys got it? Okay. Well, this is what makes catheters so dangerous, because when we put a catheter in, now if that bacteria gets inside this tube, those bodyguards are on the outside of the tube. They can't get to that bacteria. There are no checks and balances here. So if we allow bacteria into this catheter, it has direct access to the bladder. Now you think that's bad, it gets way worse. I'm going to show you in just a minute. But when we're talking about catheters, let me explain how they actually work. We put a tube in, and the tube looks like this. This is a catheter tube, and it's got a little hole at the top of it. We put that tube in. Nurses do that, not CNAs. Hey, Jake,
Yes, ma'am.
do me a favor.
Mhm.
Go get me, take this to the bathroom for me. I should have prepped this earlier. Get rid of this.
Mhm.
Give me 5 cc's. Give me 7 cc's of water, please. Okay, so nurses put catheters in. Okay, nurses do this. So I take a catheter. This is a sterile technique. So I've got sterile gloves on. I've done all the right things. I take this catheter and I'm going to insert it in through the urethra up to the bladder. Now notice the balloon is not inflated. We don't want the balloon inflated while we're putting it in. Once I get this into the bladder, then I take this port. We're going to attach a syringe to it. Thank you. We're going to attach a syringe to it. So I've got this advanced up into the bladder. And then I'm going to inflate that balloon with a certain amount of fluid, sterile water. And now that balloon is sitting right on top of that valve, and it keeps the catheter in place. It's nothing more than a doorstop. So when I'm ready to take the catheter out, I'm going to deflate that balloon just by using a syringe and pulling the fluid out. And it deflates the balloon. And then the catheter simply slides right out like a piece of spaghetti. Good. That's all a catheter is. The only purpose this serves is to hold that valve open and to direct the urine through the tube rather than through the body. But that's not going to help us because the urine's just going to come right out here and go everywhere. And now we've got, basically incontinence, and that doesn't help. So what we want to do is attach the catheter to some sort of a bag. Now, this is inside the body. The urine goes down through the catheter tubing and it gets collected into a bag that we will empty on a regular basis. Good. So I'm going to pass this around so everybody can have a chance to play around with it a little bit and see how it works. When we get to drainage bags, I'm going to pass it around again because there's something else I need to show you on the drainage bag. But you guys can play around with that. Absolutely. Yep. The only difference is that it's the same catheter. It's just inserted a little bit further because you have to go through the penile tissue. That's all. That's the only difference. Yep. The hole is the same. The urethra is exactly the same, whether it's male or female. It's exactly the same. It's just a little bit longer. Exactly the same. It shouldn't be painful.
Oh, really?
Catheters should not be painful. It's similar to if you have pierced ears, the hole is already there. Put an earring into your pierced ear. It doesn't, there's no pain. Now, if the earring is a little bigger, a little heavier, and fits snugly into the hole, that's a little bit more equivalent to a catheter. We don't want here. Okay, so if we're looking here, hold on one second. if we're looking here, right, you don't want this catheter to be smaller than the urethra, right, because the urine will leak out. So we want it to fit, but we want it to fit snugly. So there's different size catheters that we can use for different patients' anatomies. Does that make sense? So the whole goal is to have it snug, but the hole is already there. And it's very similar to putting earrings and pierced ears. The hole is there. It's just a snug fit. So there should not be pain involved. We're going to talk about pain in a minute.
Is it normal for usually men to have, like, when they get the catheter inserted, is there blood? Is it normal
No.
for there to be blood?
No, there should never be blood.
Tampa General told me it was.
No, there should never be blood. No. No. Now, if there's an obstruction such as a enlarged prostate or a tumor in the area, and we have to get that catheter somehow moved around that tumor or that prostate that's impeding, that action of kind of pushing, right, to get the catheter into place around an obstruction, you might have a little bit of blood from the irritation of the advancement. But in a quote unquote normal anatomy, no, there's no reason for blood. Okay. All right. So when you have a catheter in place and it's just holding that valve open and we've got a bag attached to the catheter at this location, this is an opportunity for pathogen entry. Good. Makes sense. But it's not the only one. It's not the only one. There's actually, we're going to come back to this in a second. Where am I? There's actually 3 places that we can allow pathogens to enter. This one up here, that's the nurse's problem. That's when the nurse puts the catheter in place. We want to make sure that we have sterile technique here, up here. So that's why nurses put catheters in, because we don't want to introduce bacteria directly into the bladder. Now, these 2 are relevant to you. This is the one that is most common, right? That because we're going to empty these bags. That is a CNA task. That is something you're going to be trained to do today, is empty this bag. Well, if you let bacteria in while we're emptying this bag down here, that's a problem, because eventually that bacteria might be able to climb and get into the bladder, but it's a long way. This opening, this is why we have to be trained for this. This opening way closer to the bladder. Look how long that catheter is. It's only about this long, right? Way closer. Down here, bacteria have to climb up the bag, climb up the tubing, and up into the, it's a long way. Here, way closer, much more dangerous. This is why you have to be trained to do this. It's all about infection control. Make sense? Good. All right. So this is one type of bag. This is what I'm passing around here. This is a bedside bag. We use this in a clinical setting or a home care setting most often. And it is designed to hold a lot of urine. So we're only going to change it once a shift. But it's very visible. I mean, it's like out there. You can see it. If somebody is out walking or in the community, they're shopping at Walmart or at Winn-Dixie, or they're even at a theme park, they don't want to be carrying around a suitcase full of urine with them. It's a bit embarrassing. People will stare because it's unusual. So those individuals want something a little more discreet. And that's why we have leg bags. Leg bags are another type of urine collection device. They're smaller and they're designed specifically to fit on a thigh or a calf and be hidden under clothing. So your patients that are ambulatory, that are out in the community, will most likely be using a leg bag. They are smaller, so they generally have to be emptied more often. Now, CNAs can help people with leg bags empty their bags. They also can help people with bedside bags empty those bags. We can do both. The way that they're emptied is a little bit different. This is a twist valve. You twist it, urine comes out. That is going to be a little bit different mechanism. That's a T valve. We're going to talk about that in a few minutes. Okay. But generally speaking, most of the, not all, but most of the time, if your patient has a leg bag, most of the time they empty them themselves because they're ambulatory. They're out. They're in the community. If they're in the community, chances are they can empty their own bag.
We always want to promote independence, yeah.
Absolutely.
Even when they're using the other kind of catheter.
Right. So we always go by our care plan. So if the nurse knows that the patient has the ability, the dexterity, and the mental acuity to be able to empty their own bags and minimize bacterial contamination, the patient will absolutely be encouraged to do so. That would be on the care plan. Yeah, so I've got a lot of things I have to think about, not just can they, but can they do it in a safe manner? Okay. So you have leg bags and you have bedside bags. This is where things get really tricky though. If we allow bacteria into this bag, bacteria don't need little boy bacteria, little girl bacteria to have baby bacteria. It doesn't work that way. Bacteria need the right environment and the right enzymes. And they literally zip themselves in half, and now you've got two. What a great way to procreate, right? So it doesn't work like it does in humans. Humans, we have to incubate a whole nother human. We got to bake it. We got to make it, right? Bacteria don't do that. They just need the right environment, the right enzymes, and they literally just become two. Now those two will then become 4, and then 8, 16, 32, 64, 128, 256, 512, on and on and on. And it doesn't take long before you've got an entire bag filled with bacteria. They're going to run out of room, so they start to climb. Now they're coming into contact with fresh urine. So they're really going to step it up. And they're going to get into the tubing. Now we've blocked out light. We've got warm, we've got dark, we've got moist, we've got all the enzymes we can need. So now they're really jumping. And they're going to climb up into the bladder. But it's not going to be 1 or 2 bacteria. It's going to be 1 or 2 trillion. That quick. They come out of these holes at the top of the catheter, and they invade the bladder. And it's not like a regular UTI where 1 or 2 bacteria come in, they set up shop, it takes a while to get going. You don't feel so well, you start taking some medication and you get better. This is 1 or 2 trillion within like 30 minutes. That quick. Overwhelming. This is why catheters, catheter-acquired urinary tract infections, or what we call CAUTIs, can kill patients. And they kill about 2,500 patients a year. So when we have a catheter in place, infection control becomes super important for us to manage. Make sense? This is also why we don't use catheters unless we have a verified reason to use one. Used to be back in the 70s, if you went into a hospital for anything, you stubbed your toe, needed stitches, you got a catheter and an IV. I mean, we just, fluid in, fluid out. I mean, it didn't matter what you were there for. You just got both. Until we started realizing that even healthy people were suffering from horrible urinary tract infections with catheters. And that's just because it's a Trojan horse. It allows all the bad guys to hide until they all jump out and, havoc. Make sense? Okay. All right. So there's 3 places that pathogens can enter. We've talked about this. One is down here where we empty it. One is here where the catheter and the bag meet. And then the other one is up here where the catheter is inserted. That's a nursing problem. So the whole point of managing a catheter is to just try to minimize bacterial intrusion into the system. And that's going to drive a lot of what we're going to do for the next 2 skills. Good? Catheters always have to be hanging on a non-moving part of the bed. That just makes sense. And they also have to be above the level of the floor. We don't want, remember, the floors are not clean. So we don't want those bags to be laying on the floor where pathogens can get onto the bag and then accidentally into the bag when we're emptying it just because of handling. So bags always above the floor. But bags also have to be below the level of the hip. If you raise that bag above the level of the patient's hips, whatever urine is in that tubing is going to go right back into the patient. And I don't know about you, but urine really should be a one-way trip. You know, I don't want recycled urine. That's pretty gross. But any pathogens that are in the tubing, it's like a water flume. They'll just bring the pathogens right into the bladder with them. So never lift a catheter bag above the level of your patient's hips. I watch a lot of shows on Discovery, a lot of health shows, and it's astounding to me how many of them have, you know, they'll show a caregiver walking a patient, direct care worker walking a patient down the hallway, you know, let's go for a walk. And they hold the catheter bag up like this as they're walking. And all I can think of is, recycled urine. Don't do that. It's gross. So be careful. Never allow that bag to go above the level of the patient's hips. Good? All right. So let's talk about the test real quick. There's a couple of ways that people fail the test for this particular skill. The number one way is that CNAs remove the catheter from the catheter tubing. They disconnect it. They take the bag over to the bathroom to empty it. So people do that on the state exam. Of course, that's going to fail you. Okay. Where we aren't authorized to disconnect those two pieces. The second way that students fail the exam is that when they're emptying the bag, they will unhook it from the bed and hold it up to get the urine out of the bag and into the cup, you know, drainage. And it makes logical sense, right? You want to hold the bag up to drain it out, but we're not thinking about what's happening on the other side of the bag and where else it's draining in to the patient. So those are the two things that you really want to make sure that you stay away from. Don't disconnect the bag to empty it, and don't hold it higher than you can, you know, kind of tilt it up. That's fine. You can hold it up a little bit if you need to, that extra space for drainage. You can squeeze it a little bit, but you don't want to just hold it all the way up, right? You have to think about what's happening on the other side of that tubing. Any questions on that? Now, let's talk about the one part of catheters that terrifies everybody, and that's having a catheter pulled out. Sometimes patients will pull catheters out, especially if they're confused. They don't belong. They feel strange and foreign. They are irritating. They shouldn't be painful, but they are irritating. So patients that don't know any better, that don't think about it, if they're on medication and maybe their inhibitions are lowered or they're confused, they can pull them out. Now, your patient is fine. They're not going to die. It's okay. But that balloon that's about this big is coming out of a hole that's about this big. So you're going to get tissue tearing, right? You're going to get blood. You're going to get probably a little mucus and definitely some urine. It's okay. Your patient is not going to die. Relax. If you get all stressed out, oh my God, what did you do? Your patient's going to take the cue from that. And then they will start getting stressed. So it's fine. What we do want to do, though, is save that whole system. Because as a nurse, I've got to act on that. There's two different scenarios here when a catheter comes out. Either the whole catheter came out or part of the catheter was left in the patient. And that happens if that balloon bursts. If that balloon bursts, it can leave a little piece of that latex back in the patient, in their urethra or in their bladder. And bodies don't do well with foreign objects. So those are two different scenarios for me to solve. Catheter came out, everything is good. It all came out. I can deal with that. Catheter came out, but a piece of it is missing. That's a whole different ballgame. The only way for me to know as a nurse which one I'm dealing with is to look at the catheter after it came out. So when a catheter is pulled out, either by the patient or in any other way, your responsibility as a CNA, we're going to get to that, hold on. Your responsibility as a CNA is to put it in a trash bag. Every trash can at the bottom of the trash can are clean trash bags underneath the bag that's there. And that's in clinical settings as well. There's always extra bags in the bottom of the trash can. Grab one of those extra bags, put the whole thing in that bag. The catheter, the bag, all of it in that bag. Leave it in the bathroom. Tell the nurse, catheter was dislodged. It's completely out. It's in the bathroom for your inspection. Now, as a nurse, I've got to figure out what I'm going to do. I'm either going to put another catheter in or I'm going to leave it out completely. But I've only got 45 minutes to make that decision. That's it. Because anytime you have injury, you have swelling. This is not a place we want swelling. But if the swelling occurs, I'm not going to get another catheter in. It's just, there's too much swelling there. I'm not going to be able to force a catheter in. Right. So can you imagine peeing through that swollen, torn tissue? Ow, that would be painful, right? But as a nurse, I've got to make a very difficult decision and I've got a very short time to make it. And I've got to get a hold of the doctor for input as well. That can take some time. So if you pull out a patient's catheter and you don't tell me until an hour later, I have no options. Patient's not getting a catheter. I have no options. So if a catheter comes out, you need to let the nurse know right away. So you're going to tell the nurse, your documentation will be based on your facility. In most cases, CNAs do not document in words. They notify nurses. The nurses then document in words. So your job is to let the nurse know right away. Okay. Now, patients pull catheters out. Yes, they do. But that's not the most common way of catheters coming out of the patient. This is catheter tubing that is looped near the floor. Your feet will get tangled in it without your awareness, and you will pull that catheter out. This is the number one way that catheters get pulled out in a clinical setting is by staff members because the tubing is coiled near the floor. So that's something we want to look at. Is the tubing coiled on the bed, which is where it should be, not near the floor? The other way that catheters get pulled out, disturbingly often, is when CNAs move a patient. If you're turning them over in bed, you want to know if they've got a catheter because that catheter has to move with them. If you're getting them out of bed to go for a walk, is there a catheter? Because if the catheter is hanging on the other side of the bed, you get the patient up and you start walking, it's going to get pulled out. Guaranteed. If you're transferring a patient from bed to a wheelchair, is there a catheter? So any mobility skill requires that you look for a catheter. Good? Make sense?
Something that would be documented on the care plan always.
As far as
Catheter, patient needs a catheter.
yes, because you're going to have catheter care once a shift and emptying the drainage bag. So yes.
Technically would be aware before you're even doing anything that the patient has on.
Ideally.
Yeah.
But let me give you a scenario. You're working a 12-hour shift. You've got 12 patients. On hour 5, this patient suddenly needs a catheter. The nurse puts one in. Hour 5. You're on lunch break. You're not notified. You have no way of knowing. The nurse is going to put it on the care plan at some point. But she's got other things to do as well. So that catheter may not make it on the care plan immediately. So yes, it's a good idea to take a look and see if there's a catheter before you move the patient. Ideally, yes, you should know. It should be on the care plan. But I'm going to tell you that, bless you, in a lot of places, things move so fast that the care plan isn't going to keep up with the actual reality of what's happening with the patient.
And your job is to observe as well. So
Right.
you should observe.
You should observe. Yes. All right. So there's a couple different types of catheters. The one that I passed around to you, the one we've been talking about so far, are called indwelling catheters. They have a balloon that's inflated by water to keep them in place. We put them in, we inflate the balloon, we leave them in. But what if we don't need to leave the catheter in? What if I just need it quick, insert it, empty the bladder, take it away? Quick, not leaving it. Well, we don't need the balloon then. So we would use something called a straight catheter, also called an intermittent catheter. And it's got a third name, a Red Robinson, because some dude named Robinson invented it. Okay. You need to know this as a straight catheter or an intermittent catheter, because you may be asked by the nurse, hey, go to the supply closet, get me a straight cath. You need to know what it is. Okay, good.
They mark red.
Most straight casts are. They're Red Robinsons, yeah. Again, you will go through an orientation wherever you work, and they will tell you what they use in their facility. Remember I said I was working in purchasing, and there's, 42 different syringes? Why? So every facility is going to have their own preferred vendors and supplies. You will learn them when you're in orientation, what they're using at that facility. So we have our indwelling, called a Foley. We have our intermittent or straight cath. And then we have a different type of catheter. This is an external catheter. This also has 3 names. External catheter, condom catheter, because it goes on very similar to a condom, or a Texas catheter. Don't ask, I don't know. Yeah. This is used for men, goes on over the shaft. It, again, just like this and this, it has a port to attach to some sort of a collection device, whether it's a leg bag or a bedside bag. It's going to connect in at the port. Same process. These can be left on for 3 days. Now, we're cutting the infection risk here because we don't have a tubing that can harbor those bacteria and hide them from our white blood cells. So we are cutting the infection risk, but there's always a trade-off. Even though we're cutting infection risk, we're increasing the likelihood of skin issues. Because this tip, it's a reservoir tip, it's going to allow urine to sit right up next to that tissue. And for 3 days. And remember, adult urine was acidic. Remember we talked about that? So this can actually cause what we call maceration or an eating of the skin at the very tip. And that can be very painful for our patients. So these are going to be changed every 3 days or as often as directed on the care plan. And when you change a condom catheter or an external catheter, good skin care is pivotal. We have to make sure that the skin is super, super clean and dry. In most cases, you'll also have an extra step. You'll be applying something called skin prep to the surface of the skin. It looks like a little alcohol pad. That's actually what it looks like, but it's a sticky protective coating that goes on over the skin to help protect the skin from direct access to the urine. Okay, follow your care plan for that particular patient. Some people are allergic to skin prep, so they can't use it. Follow your care plans. All right, so when we're doing catheter care, we already know this part of it. We're going to clean, we're going to use that leaves method, and we're going to clean the peri area the way we did for peri care. But I want to hold that catheter up out of the way. I got to get to the peri area. The catheter's there. So I'm just going to kind of hold the catheter out of the way a little bit, and I'm going to wipe down the center, fold it over, one side top to bottom, fold it over, the other side top to bottom, fold it over, skin fold it over, skin fold. Exactly like we did for peri care. No change, just hold the catheter out of the way. Good? Whatever we wash, we rinse. Whatever rinse, we dry. All right, remember you always go away from the urethra. When you're cleaning the catheter itself, okay, so we did pericare. We wash, we rinse, we dry. When we're cleaning the catheter itself, we're going to hold it where it exits the body. We want to hold that catheter in place. We don't want to tug on it on the inside. So we're going to take 2 fingers, hold it right there where it exits the body, and then I'm going to take washcloth number 3, apply soap to 4 leaves. I'm going to wrap it around that tubing and wipe away from the body. And then I'll fold it over. Wrap, wipe away, fold it over. Wrap, wipe away, fold it over, and wrap, wipe away. 4 strokes. So pericare is 5. The pericare part is 5 strokes. Cleaning the catheter is 4. When we did pericare was 5. Cleaning the bat side was 4. So it's always 5 and 4.
Same tube gets wiped down 4 times.
4 times. Yep, 4 different leaves. Yep. Good? Whatever we wash, we. Whatever rinse, we. Dry. All right. So this whole skill, if we looked at it from beginning to end, we're going to read our care plan and follow it. We're going to do our opening. We're going to get a barrier. We're going to get our water and ask our patient to check it. We're going to use a privacy blanket, and we're going to prepare the patient just like we did for pericare. You want to get your gloves on and place a chucks under the patient to keep the bedding dry while we're cleaning. So scoot and roll. We're going to put the chucks under the patient. We'll prep them by rolling that gown up inside the privacy blanket, putting a towel over their legs. And then we're going to get our washcloth, soap 5 corners, and hold the catheter and wash downward away from the urethra. Middle, side, side, skin fold, skin fold. And then we're going to rinse, middle, side, side, skin fold, skin fold. And then we're going to dry top to bottom. Then we're going to wring out our washcloth number 3, put soap on 4 leaves this time, hold the catheter in place, wipe the washcloth around, and wipe away from the body down the catheter tubing. We'll do that 4 times, and then we'll rinse 4 times. Then we'll use the towel to dry away from the body. Once we've done that, we're going to remove the towel, pull the privacy blanket back down, restoring the gown, scoot and roll to keep the patient from being on the edge of the bed, and take that chucks away. Get them back to the middle of the bed. They're fine. They're in the middle of the bed. They're covered with a blanket. They're safe. Everybody's happy, but we got to put all this stuff away, and we need gloves to do that. So we're going to take all of our dirty linen and put it away. We're going to clean our basin the way we clean every basin and store it. And then we can take our gloves off. Once we have our gloves off, we can take that privacy blanket away, and then we're going to do our closing. Good? I told you guys know how to do this already. You just needed to learn a little bit about the catheter itself. Questions?
You fail if you use more than 2 gloves. At some point, you just decide to take all your blood and then you grab another pair.
That's fine. Yeah. Thanks. Yeah, they won't mark you off for that. All right. Now, I would normally show you the video for catheter care at this point, but I want to go right into teaching you about how to empty this drainage bag. And I'm going to show you these 2 videos back to back. Okay. All right. So page 164 is going to talk to us about drainage bag. Oh, Jake, reminder, we need to change the clocks back. So if you look at the principles down the side here, they're all spelled out for us here. There's nothing new to learn. We know to follow the care plan, do our opening. We'll need gloves for this. We need a barrier. We're going to clean the basin the way we clean everything else. We're going to do our closing. Again, down here, you'll see that this is going to be done on a mannequin. They're giving you 9 minutes to empty this bag into a cup and measure it. Way more time than you need. Way more time than you need. I mean, this is maybe a 4-minute skill, maybe. If you're really taking your time. Not hard. All right, if you look at page 165, at the top of the page, we see our care plan. It says empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. Now here you can see a small version of the intake and output form. If you keep your hand there, go to page 169. You will see a larger version of that form. All right, so to review, there are 2 different types of bags. There's a bedside bag, holds more. There's a leg bag, holds less. Both of them have an emptying port of some sort. This one is a twist valve. It just twists and the urine comes out. This is the one we're going to use for the test. This is what we're using for the test. This valve is different. It's a T valve. So we have to talk about T valves now. All right. So when we are emptying the drainage bag, we're going to place a chucks on the floor, and then we're going to set our cup on the chucks. Don't put the cup directly on the floor. Nothing goes on the floor. You guys remember that? Nothing goes on the floor. So we're going to put a chucks on the floor, cup on the chucks. You have to have gloves on to handle the cup. Please make sure you put gloves on to handle the cup. I know that should be self-explanatory. So the whole point here is that we don't want that port to touch anything. This port can't touch anything, because if it touches something, it's going to get contaminated. That contamination will go into the bag, into the tubing, and eventually into the patient. Not a good idea. So when we empty this bag, this port can't touch anything. It can't touch your gloves. It can't touch the cup. It can't touch the bed. It can't touch the chucks. It can't touch the sheet. It can't touch anything. Now, we used to, years ago, wipe the port off with an alcohol pad after we emptied the bag. But what we found out through studies was it sounds like a great idea, right? Any pathogens that are on there, we're getting rid of them. That's an awesome idea. However, alcohol is a drying agent. And what it was doing was drying out this material, this polyethylene or polypropylene, whatever it is. And when it dried it out, it caused little micro cracks to form, and that harbored bacteria. So what we thought was a good idea turned out to be not a good idea. So we changed our process, and now we don't wipe it off with alcohol. We just try real hard not to let it touch anything. It's also why we have to change it out once a week, more often than the catheter. Because if pathogens do get into this bag, it's going to take them a very long time to climb. So if we change this out once a week, it's less opportunity for pathogens to get into the actual catheter and ultimately the patient. Good? Make sense? Okay. So that port can't touch anything. So this is a T valve. And the way this works, Jake, I'm going to need a close-up. Put this on the back here.
So not cooperating here. There we go. Flip it to the right.
Down. 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 There we go. Okay. So this is a T valve. Wow, that is really close. This is a T valve. It has a little house. Remember the house. We're going to talk about that in a minute. So we're going to remove it from its house. And if you look at it, if you look through it, there, where is it? You can see, oh, can you guys see that?
Try to bring it in closer.
No, 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 no. There we go. Okay. You can see that it's closed. You guys see that? Okay. To open it, we're going to push this little protrusion here, and that opens it. Now you can actually see through. You guys see that? All right. The biggest mistake that's made when you're trying to open and close this valve is that most people put a finger here for leverage. I told you, you can't touch this. So when you're doing this, you've got to make sure that you don't touch that end. So we're going to open the valve to empty it into our cup without it touching anything. And then we close the valve, not touching the end. And then ever so carefully, we're going to put it back in its little house without it touching anything. So you don't want to do this. Good? Makes sense? When you put this back into, you open it to empty. When you put it back into its pouch, it must be closed, not open. Very important. Close it and then put it back in its house. All right, Jake, go ahead. Oops, I'm off. Sorry, I'm off center. Put it back into its house. All right. Questions?
Bring it back in.
That's good. I have to get so far enough off screen that you guys can see the screen. All right, any questions on that? So once we get the urine from the bag into the cup, we're going to take this to the bathroom area. For the test, it'll probably be a bedside commode. You cannot carry an open container of urine anywhere. We have a chucks on the floor. So we're going to wrap the chucks around our container and take it to the bathroom. When we get it to the bathroom, we're going to set the whole thing, the chucks and the container, on the lid of the toilet, the whole thing. And we're going to unwrap it. Because when we go to measure this, there's 3 things on this line that have to be present for us to get credit. If you miss any one of these, you miss the whole line. You have to measure this on a barrier, on a flat surface, which is the toilet. You can't hold it up to measure. And it's got to be at eye level. So you're going to put this down on the lid of the toilet, unwrap it, and then you're going to get down and read it at eye level. If you fail to do any one of these things, you don't get credit for any of them. This is a very important checkpoint. Good? I don't know who would think this is a good idea. We're going to wash our hands before we document, after our closing. And then after we document, what do we need to do again? Wash our hands. But let's talk about documenting. When you document, you're going to be told to document on an intake and output form. That means that both sections will be present on the form. It's what you see on page 169. You have to document on the output section. If you make a mistake and you document up here, you are legally declaring, hand on the Bible, that this patient drank urine. That's what you're doing. When you document, everything you put on medical documentation is hand on the Bible, swear in a court, this is true. It's a legal form. So if you make a mistake and you document up here, this is intake, you are saying that the patient had however many cc's of urine in, not out. Now, of course, you're going to get into a courtroom. You're going to go, well, nobody would drink urine. No, it's not true. You declared somebody did. Why am I supposed to believe you now if you're telling me not to believe you then? Lawyers can be vicious. Their paycheck relies on it. Don't think they're going to be nice to you. Good? Makes sense? All right. So make sure you're in the correct space. Let's talk about this, though, time. You should be documenting in military time. If you don't know how to document in military time, there is a lesson in this book on how to document in military time. Do the lesson. It's super easy. I'm not real sure how time got to be what it is today. I don't know who made this decision, but along the way, somebody said, okay, how many hours are in a day? 24. So let's count to 12 and then, I don't know, start over. I mean, why? Why did that conversation happen? I mean, was it because people couldn't count past 12? I don't know. But why did that conversation happen? If we have 24 hours in a day, let's use all of them. And that's what military time does. So instead of starting over at 1, we're going to go to 13, and then 14, and then 15, and then 16, and all the way to 24, because there's 24 hours. Let's use them all, which makes a whole lot more sense to me than going to 12 and then starting over, right? So there's a lesson in the book on how to do military time. But if you get to the test and you don't know military time and you're freaking out about it, just put regular time, but you have to put AM or PM. You have to put AM or PM if you're using non-military time. Okay? You're going to put urine because that's what we're measuring. And then you're going to put how much you measured and your initials. This is going to be measured in mLs or cc's. Our care plan told us to. mLs or cc's. This cup that you're going to use, this is the cup you'll use on the state exam, has mLs or cc's, but it also has ounces. Do not use the ounces side. That's not what we're using, mLs or cc's. So here, in order to measure, you are going to round to the nearest number. So I'm going to pass these two things around so you can practice with the T-valve and you can look at the measurement on the graduate container. So we're going to read our care plan. We're going to do our opening. We're going to put the barrier on the floor, put our gloves on, and get our cup. We're going to empty the bag into the cup, not letting the port touch anything. We're going to close the port, put it back in its house. Don't let it touch anything on the way. We're going to wrap the chucks around the cup, take it to the bathroom, unwrap it, and we're going to get down at eye level to measure. Now, when you're looking at, I don't have it on here. Okay. So when you're looking at this, I used to have a slide. It's not on this presentation. When you're looking at this, each one of these is going to be marked in 50s. So you'll see a line for 350, another little line, a line for 400, a little line, a line for 450, a little line, 500. They're marked in 50s. The little lines are 25s. You want to round to the nearest line. Doesn't matter whether it's up or down, just nearest line. So you're not going to put 540 cc's. If it's nearer to 550, you're going to put 550. If it's nearer to 525, you're going to put 525. Don't put anything other than 25, 50, 75, or 00 for your measurements. Make sense? Now, bags do have markings on them, but they're not accurate. Those are for eyeball use only, just to estimate. We're doing something more scientific. Okay. We're going to dump it into the toilet. We'll rinse it, dry it, and store it like we do everything else. We'll remove our gloves. We'll do our closing. We'll document, and then we'll wash our hands again. And that is how we empty the drainage bag. The video I'm going to show you in just a few minutes has a very close up of the drainage bag, so you should be able to measure, or of the cup, sorry, you should be able to measure along with me. So the first video we're going to watch is catheter care, and then we'll go right into emptying the drainage bag. I'm going to show you these two videos back to back. And that will finish us up today, and the rest of the class will be practice. Yep. Good afternoon, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I'd like to perform catheter care. Is that okay? Okay, I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, we're going to need one underpad. We're going to need a towel, 4 washcloths, 1, 2, 3, 4. We're going to need a privacy blanket. We'll bring this over to the patient area. And I'm going to need a basin and soap. And a set of gloves. All right, Miss Jones, I'm just going to fill your basin. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about 1/4 of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. Okay. I'm going to place this privacy blanket over you, and this is going to help keep you warm and provide privacy as we do this skill. So I'll lay the privacy blanket over the sheet without snapping it or shaking it, and then pull the sheet down to about your waist. I'll put the washcloths in the basin. That way they get warm. And I'm going to prepare the underpad to go under the patient. I'll open it up. I'm going to hold it up lengthwise with the absorbent side facing me, and I'll roll it all the way to the end. Now I can put my gloves on. Okay, Miss Jones, we're going to place an underpad under you to keep your sheets dry while we do this skill. So I'm going to place an underpad on the bed. And in just a moment, I'm going to ask you to scoot toward me. I'm going to roll you on your side, and then we'll spread that underpad out. So on the count of 3, go ahead and scoot toward me. 1, 2, 3. Thank you. And now I'm going to roll you on your side. 1, 2, 3. And as I roll the patient, I want to be careful not to put any stress on this catheter or the tubing. You don't want it pulling tight. So I'm going to unroll the chucks underneath the patient and tuck it under her hip. Miss Jones, come on back and scoot to the middle of the bed, please. Okay, Miss Jones, we're going to repeat the process. Go ahead and scoot toward me. And we're going to roll you onto your left side. 1, 2, 3. And I'll smooth that chucks out underneath the patient. Come on back onto your back. And then scoot to the middle. Now we can begin the cleaning. Ms. Jones, I'm going to expose you. I'll make this as brief as possible. But please let me know if you're uncomfortable in any way. I'm going to roll the privacy blanket, making sure that I get the gown inside the blanket as I roll it. But I don't want to grab that catheter as I'm rolling the blanket. So you want to be very gentle with this process. This is going to expose the peri area. And then I'll place a towel over the upper thighs and make sure that the catheter tubing is on the towel. This is to help minimize exposure, increase comfort, and gives a place to put the catheter while we're cleaning it. Now I'm ready to start cleaning. I'm going to take my first washcloth, wring it out, and I'm going to soap 5 corners. 1, 2, 3, 4, 5. I'm going to hold the catheter out of the way, retract her labia, and then wipe down the center, top to bottom, and then move away and fold that leaf. The second leaf will wash the outside of the labia, top to bottom. We'll fold that leaf over. This is going in one direction only, top to bottom. This third leaf is going to wash the other side of the labia, top to bottom. We'll fold that over. The fourth leaf will wash the skin fold between the leg and the groin, top to bottom. We'll fold that over. The last leaf will wash the skin fold on this side, top to bottom. Now we'll set that aside on the barrier. And whatever we wash, we rinse. So we're going to wring that washcloth out really well. Hold it using the leaves method. I'll hold the catheter out of the way and open the labia and rinse down the center one direction, top to bottom. We'll fold that over. We'll rinse the outside of the labia, top to bottom, fold that over. The other outside of the labia, top to bottom, fold that over. This is going to rinse the skin fold. Fold that over, rinse the skin fold. We'll set that aside. Now we're going to clean the tubing. So I'll get washcloth number 3, wring it out really well, hold it using the leaves method, and I'm going to soak 4 leaves. 1, 2, 3, 4. I'm going to hold the catheter where it exits the body so it doesn't pull on the inside. Wrap the washcloth around the catheter and wipe away from the body. We're going to fold that over and repeat 3 times. Hold the catheter, wipe the washcloth around, and move away from the body. 2, 3, changing the leaf for each stroke, and 4. We'll set this aside. Whatever we wash, we rinse. I'm going to wring the rinsing washcloth out thoroughly, hold it in the diamond shape in my hands, hold the catheter where it exits the body, wipe the washcloth around, and rinse going down the catheter. We'll fold that leaf, rinse 2, fold that leaf, rinse 3, fold that leaf, and rinse 4. We'll set that aside. Whatever we rinse, we dry. So we'll dry the peri area top to bottom and the catheter tubing. We can remove the towel, set it on the table, and we're going to unroll the privacy blanket, trying to be careful not to touch that gown with your soiled gloves, and we'll cover the patient up. Mrs. Jones, can I get you to scoot toward me, and I'm going to remove the pad that's under you. Go ahead and scoot toward me, and on the count of 3, you're going to roll up. 1, 2, 3. I will roll the soiled chucks toward the patient and tuck it underneath her hip. Come on back, Miss Jones. When I'm moving Mrs. Jones, because my gloves are soiled, I'm only touching the outside of the privacy blanket. Mrs. Jones, scoot to the middle of the bed, please. And now we can remove your chucks. If you can scoot toward me, again, my soiled gloves are only going to touch the outside of the blanket. And then you're going to roll up on your side, 1, 2, 3. And I'll remove that chucks from under the patient. Come on back onto your back. And then if you can scoot to the middle. Thank you. I'm going to go dispose of this. Okay, Mrs. Jones, you're covered. You're safely in the middle of the bed. I'm going to go dispose of your linens and clean your basin. I'll be right back. These items will go in dirty linen. We're going to clean this basin the way we clean all basins. I'll bring the basin to the sink and we'll dispose of the water in the sink. Rinse the basin and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. Now we can dispose of the barrier. This will go in the garbage. And I can remove my gloves. Okay, Miss Jones, I'm going to remove your privacy blanket now. I want to check your tubing real quick just to make sure that it's not kinked and you're not lying on it. So it looks good. It's not near the floor. So I'll pull the sheet up over the privacy blanket. This ensures that you're always covered. And I'll remove the blanket as I do so. Want to make sure that the blanket is rolled into a ball so trailing edges don't contaminate other surfaces. We'll make sure that the sheet looks good. All right, Miss Jones, just let me go dispose of this in dirty linen. I'll be right back. We'll adjust the sheet on this side. There you go. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your bed is in the low position. Your environment is clean. Here's your call light. If you need anything at all, go ahead and press the red button. We'll be happy to come help. I'm going to open your curtain and return your overbed table to storage. Now I'll go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Good evening, Mrs. Jones. How are you today? Fantastic. I need to empty your urinary drainage bag. Is that okay? I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get my supplies. We're going to start with the chucks. This is going to go on the floor under the bag. We're going to place the barrier on the floor directly under the urinary drainage bag. So we'll unfold it and we'll place it under the bag with the absorbent side facing up. I'm going to go get a set of gloves. And we're going to get the graduate container out of the drawer. You need to make sure that you put your gloves on before you get the graduate container. We're going to place the container on the barrier directly underneath the bag. We use the emptying port to empty the bag. This is a T-valve. We slide it to the side to open the valve, and then we're going to empty the urine into the graduate container without letting that port touch anything. Once the bag is empty, we'll close the port and place it back in its little house. All right, Ms. Jones, I just want to check to make sure the tubing is coiled on the bed and you're not lying on it, and that it's not coiled near the floor either, where it could become a tripping hazard. Now, I can wrap the chucks around my graduate container for safe and secure transport to the bathroom. We're going to set it down on the lid of the bedside commode and unwrap it, turning the cup around so that we can read the amount of urine that's in the cup. We need to be at eye level. It needs to be on a flat surface and on a barrier. I'm going to throw the chucks away. Open the lid and the seat and dispose of the urine into the bedside commode. I'll rinse the cup and dispose of the rinse water into the bedside commode as well. We'll close that, set the graduate container down in the sink, and disinfect it per facility policy. I'll pick it up with a paper towel, dry the inside with a paper towel, throw that away, dry the outside with a paper towel, throw that away, and one more for the drawer. Okay, Miss Jones, I'm just going to return this to storage using a paper towel to open the drawer and closing the drawer. We'll throw those paper towels away, and then I can remove my gloves. You take a peek at your tubing just one last time. Everything looks good. Are you comfortable, Mrs. Jones? Is there anything else I can get for you while I'm here? No? Would you like a magazine before I go? Your bed is in a low position. Your environment is clean. I'm going to open the curtain. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come back and assist you. Thank you very much. I'm going to go wash my hands. After washing my hands, we'll document the amount of output on the documentation sheet provided by the evaluator. We're going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. And we want to make sure that we're documenting in the output section. After documenting, I'll wash my hands one final time. After washing my hands a final time, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. I got it. I'm still muted.
You got muted.
Oh, okay. All right. Any questions on that? Final chapter of homework tonight. You're going to have chapter 10.
I have a quick
Yes.
question. The container that she empties into the commode and then rinsed it and emptied it. Okay, I answered my own question. Sorry.
No worries. You have one chapter of homework tonight, chapter 10. It's our last chapter. It's all on employability, conflict resolution, communication, that type of thing. We'll go over some of that in class on Wednesday as well. Tomorrow is the game show. Don't forget, 11 a.m. on our YouTube channel. And Jake will probably send out a text message with a link so that you can just click the link to join if you want. Any questions before I go? Sign off. Any questions? All right, those of you joining us virtually, thank you so much for tuning in. Make sure you join us tomorrow for the game show, Wednesday for graduation. That's going to be an important one because it's going to give you some insider information you probably don't have about employment and healthcare. So I hope to see you there. Until next time, happy caregiving. Bye.
I'm just gonna leave it up for just a moment, see if anyone has a question.
Okay.
My apologies.
No, you're fine. All right, the rest of the class for you guys is going to be practice. Once we sign off, that way they don't need to see you guys practice. Once we sign off, you guys are welcome to, practice any of the skills that you've learned so far. The mannequin skier, you can take her out of bed and just put her on the floor over there if you need to practice live patient skills. You're not required to stay for practice. It's open for you, but you aren't required to be here. You're not required to practice, although I would take advantage of it if I were you. And we will be passing around a sign up practice form on Wednesday for the following week. So Monday and Wednesday for the following week, we will have practice time, but it's by reservation only. So keep that in mind. You'll be able to sign up for that next week or next class. All right. Any last questions?
The sign up practice reservation by whatever only. Does that mean you only want one person practicing at a time?
No, it just means that I have to tie Jake up
Oh,
to be here, and I don't want him sitting here. People say that they're going. That's what happens. People say, "I'm going to come practice," and then he's here for 4 hours sitting, and nobody shows up, and that ties him up from doing the things that he has to do. So I make people basically, reserve
yeah.
so that he knows, okay, nobody's going to be here until 11 a.m., so he's not going to be here until 11.
Would that sign up sheet still be open next class?
I'm going to be passing it out next class. Yep. Good. Any other questions?
Nothing from chat.
Nothing from chat. All right. Thank you so much. We'll catch you next time. All right. The